This is a chest radiograph on an 82-year-old male patient. The reason I'm showing you the case is this highlighted structure. Have you figured what this structure represents? This mesh-like appearance and the rounded edges are consistent with a stent. Of course, this is too big for a coronary arterial stent, and this is not the location for such a device. The appearance is not that of a typical prosthetic valve. But if you think about the location, it's really in the area where you expect the aortic valve to be. So this is an aortic valve stent, and it's not a typical aortic vascular stent, which would be higher up. Another hint to the fact that this is not a typical surgically inserted valve is the absence of median sternotomy wires. Now let me tell you more about this case. This patient had symptoms secondary to severe aortic stenosis. The classic known treatment for severe aortic stenosis is replacing the valve by surgical means. Unfortunately, this entity of severe aortic stenosis is very common in elderly patients with multiple comorbidities. Many of those patients are not candidate for surgery since surgery itself may lead to very high morbidity and mortality. Aortic stenosis that is severe is an entity that is associated with very poor prognosis, and patients don't live long. So those patients are left with the unfortunate choice of dying from aortic valve stenosis or from the surgery itself. And this led to what we're looking at now, which is insertion of the valve by non-surgical means. This option of inserting the valve in the catheter lab through a femoral arterial approach, where the operator uses the catheter to introduce this device, which is the stent, which is then placed in the location of the aortic valve to open it up and get rid of the stenosis. This procedure is known as transcatheter aortic valve implantation or replacement. The procedure known as Tavi or TAVR has been a game changer. This is a procedure that gave those patients an option and has been gaining very rapid momentum over the last few years. So severe aortic stenosis, a disease killer in such a population, has been treated successfully with patients, instead of dying within a few months, living for years and up to 10 years now. The indication started with these elderly, highly morbid populations, the high-risk ones, but it has been also used now in intermediate-risk patients. Given the success of this procedure, it wouldn't be surprising to see younger, low-risk patients being treated by this in the near future. The femoral approach is not the only approach. This has been approached by trans-subclavian or trans-radial approaches. Some institutions have also tried inserting this directly through an opening through the ascending aorta. A transapical approach by which an opening through the apex of the left ventricle is used to reach the aortic valve and place it has been used. However, this has been abandoned currently in the view of the other easier and more successful approaches. Two different types of valves could be used: a valve that is self-expandable or balloon expandable. Let me show you the catheter images of this very neat procedure. This is the catheter that has been introduced through a right femoral arterial approach, and it curves all the way up to go into the heart, going through the retrograde approach into the descending aorta, aortic arch, ascending aorta, and then into the left ventricle, crossing the valve. Using this wire as a guide, a sheath is introduced, and you see the operator pushing the device using that. And here the stent over that sheath has been pushed all the way to reach the desired location. Now to the cool stuff. This is a balloon expandable stent, since a balloon has to open it up. Let's see what's happening. The operator inflates the balloon, expanding the narrowed stenotic aortic valve region, and contrast is injected to delineate the aortic root and the ascending aorta. And now it's clear how the aortic valve stenosis has been opened up using this stent, which is a balloon expandable type. Now, after seeing that, it's easy to understand what you're looking at on this chest x-ray and understanding the post-Tavi appearance. What I didn't show in this case is the value of utilizing cardiac CT in assessing the pre-Tavi patient. This is a relatively interesting and huge topic that has multiple points that we could emphasize when we show that later. So keep tuned to a next clip, hopefully in the near future, where we discuss that topic. To summarize what we learned today, we discovered that there is a new way of treating aortic valve stenosis. This has changed the game for patients who have severe aortic stenosis and are contraindicated for surgery. The procedure has improved the prognosis in those patients and has gained momentum, and that's why it has been used also in intermediate risk population. There are different approaches to inserting this by a catheter. The most likely would be a femoral approach. We have two types of stents that could be placed currently, balloon expandable and self-expandable stents. And finally, we learned how a post-TAVI chest x-ray may look like. Thanks for watching. See you with more cases later this week. This is a 35-year-old male patient who presented with acute right lower abdominal quadrant pain. Here's the coronal image. Now, I had several requests to show bread and butter common pathologies that we see every day, and this is one of those cases. However, this case has a very neat associated teaching point. With the right lower quadrant or right iliac fossa pain, one of the major differential diagnoses would be acute appendicitis. In a previous clip, we did discuss on how to look for appendix on a CT scan. Quickly revising that, you look at the cecum and try to identify the terminal ileum and the ileocecal junction. The appendix arises from below that region, and that's what we see here. In this case, both the large and small bowel lobes are opacified since the patient received oral and rectal contrast. And here you see a mildly enlarged appendix with some wall enhancement and no contrast within. Add to that you see streaks of fluid and fat stranding, and we've learned several times now that fat stranding is a sign of inflammation. In this region, you could identify a slightly L-defined appendicular tip. As you follow this all the way backwards, you'll reach the attachment of the appendix to the cecum, what we call the appendicular base, which is also thickened. And this is probably the reason why contrast that's really filling the cecum could not go in and fill this obstructed appendix. Lack of filling of the lumen of the appendix by well opacified contrast within the cecum may be a sign of inflammation. Now, all of that is cute and neat. We know that we have to look for an acute appendicitis given the provided clinical information. Your job does not stop here. You need to make sure that there are no features of perforation. Namely, make sure you don't have free air in the abdomen, which was not present here. Look at the entire abdomen, since air may go all the way up to non-dependent regions, and change the window to lung windows to make sure you don't miss those. In this case, there was no free air. Another thing to look for is the associated of a large inflammatory mass, which we call a phlegmon or an abscess. Since these findings may indicate more urgency in treating the patient or might change the management. Now, none of that was present, so you don't have free air, you don't have an abscess, you don't have an inflammatory mass. However, you have another important finding. And the neat teaching point I was telling you about actually evolves about this finding here. This is a rounded high-density focus that is outside of the lumen of the bowel. It has equivalent density to the bones, which could be seen on bone windows. This free calcific density is in the right iliac fossa residing on top of the iliopsoas muscle that we see here. Now, what could be calcified and resides here? It's a very unusual location for calcification within a vein, what we call a phlebolith. Given the absence of calcified lymph nodes elsewhere, this would be unusual for an isolated calcified lymph node in this location. Now, linking all findings together, this probably represents a stone that was within the appendix, which is scientifically known as an appendicolith, which means a stone of the appendix. Now, stones within the appendix may be even seen in asymptomatic patients, but it's known that patients with appendicitis may have a higher incidence of those. The important point in this case is that you see the stone outside of the inflamed appendix, rather being inside the lumen. And although we don't have free air or collections, this tells you that this appendix has perforated at one point. If you're wondering why there is a perforation without the presence of free air or larger amount of fluid, we know that sealed perforations could happen in appendicitis. Although this is a subtle finding, this changes the way you're going to report the case. Your conclusion would be acute appendicitis with a sealed perforation. So let's summarize what we learned. We know that a common reason for right iliac fossa pain is acute appendicitis, which you could image by CT. We revised the way to look for appendix on a CT scan and discussed a few features of acute appendicitis, namely wall thickening, abnormal enhancement surrounding fat stranding, and we emphasized to look for signs of perforation. Make sure you don't have free air, a phlegmon, or an abscess. And when you see an inflamed appendix, such as what we see here on the coronal image of this same patient, make sure you don't have a free appendicolith. Here's the appendicolith on the coronal image, and this could be close or even far away from the appendix. It changes your report from no perforation to at least a sealed perforation. Thanks for watching. Your comments are appreciated, and see you later. A 74-year-old male patient who presented with headaches. You've seen the T1 MRI. This is the T2. And this is the flare. When you see an intracranial mass, you have to decide if it's intraaxial within the brain parenchyma or extraaxial coming from outside. The intraaxial nature of this abnormality is clearly seen on this coronal T2 image. So this is a lesion within the white matter in the subcortical area of the left frontal lobe. The intraaxial nature of this abnormality is very clear since it's far away from the CSF, which is outside here. And if you compare the involved area on the left side to that on the right, you're going to see that you don't have sulci. That means that this is a lesion that's facing the sulci. So this lesion bulges the parenchyma outside and compresses on the sulci, which should be seen like this. The lesion itself is well defined and rounded, but is surrounded by this area of high signal intensity within the adjacent white matter. This is consistent with fluid in the white matter and denotes adjacent edema. We learned before that fluid is white on T2 and dark on T1, and this is your rounded lesion on a T1 acquisition with adjacent fluid that is dark on T1, consistent with edema as well. The lesion itself has a relatively thick capsule on T1 that's a bit bright with a center that's very dark. And this is the appearance of the abnormality on T2. There's the edema outside and the rounded lesion that has a capsule and an internal area that's bright. So putting all things together, the thick outside capsule is soft tissue and the center is probably necrotic. So peripheral edema in red, soft tissue capsule in blue, and necrotic center in green. This is the lesion on flare where fluid is suppressed, so the edema still appears bright. The central necrotic fluid is dark here. Now to the more interesting part, which is the appearance of this abnormality after giving intravenous contrast. As you see, there is intense enhancement of this relatively thick and somewhat nodular capsule, with a persistent low density and no enhancement of the surrounding edema and of the central necrotic component. Here's another look at the lesion on the coronal post-intravenous contrast acquisition and on the sagittal post-IV sequence as well. The main teaching point of today is to discuss the differential diagnosis of an intraaxial ring-enhancing lesion. The first category to consider is that of neoplastic processes. Neoplasms may be due to metastasis, a primary brain neoplasm such as a glioblastoma multiforme, or even lymphoma, which could be necrotic if the patient is typically immune compromised. The second category would be that of infections, which includes abscesses, tuberculosis, cysticercosis, and hydatid disease. A third category would include demyelinating disease, such as severe forms of MS known as tumefactive MS. With demyelinating enhancement, the rim is usually incomplete and the incomplete opened border is usually towards the cortex. With demyelination, you'd expect to see multiple abnormalities. However, tumefactive MS may occur as a unifocal lesion. The fourth category includes that of iatrogenic causes, such as after radiotherapy or surgical treatment. Radiotherapy itself could have an enhancing lesion, and a post-surgical cavity may show an enhancing rim. The fifth category is the category that I call mimickers, which are subacute infarctions, hemorrhage, and contusions. Given the presence of a thick nodular rim, central area of heterogeneous necrosis, focal, non-extensive surrounding edema, and the absence of a primary tumor, this was favored to be a GBM. Glioblastoma multiforme, or GBM, is a high-grade primary neoplasm of the brain, and the lesion was resected in this case and was proven to be a GBM. We learned from this case that if you see an intracranial mass, you have to decide if it's intraaxial or extraaxial. We also discussed the important differential diagnosis of an intraaxial ring-enhancing lesion, which includes neoplasms such as metastasis, GBM, or lymphoma, infections such as abscess, TB, neurocysticercosis, or hydatid, demyelinating disease such as tumefactive MS, iatrogenic causes such as post-radiation or post-surgical appearances, and the so-called mimickers such as subacute infarction, hemorrhage, or contusion. Thank you for watching. More cases later.